My name is Sherry Guess, and this is the Heavily Metalled Podcast. On this podcast, I interview patients, medical professionals, and industry insiders, having important discussions regarding the all too commonly experienced but lesser identified symptoms of hypersensitivity to metals contained in implanted medical and dental hardware, diet, and environments. These metals often cause a variety of dysfunctional immune responses, chronic pain, and other syndromes that fly under the radar of most patients and physicians. During these interviews, the patients and I discuss ideas for managing symptoms, share personal lifestyle modifications, and talk about how to advocate with and educate providers pre- and post-surgery, along with options found for implant removal and the how-to of adverse event reporting. This podcast does not give medical advice. From time to time, I may interview medical professionals that render personal opinions you can use to follow up with your individual provider. Let's roll. Hello, metalheads, and welcome to the jungle. Thanks for coming back for this episode of the Heavily Metalled Podcast. You guys are in for another treat. Today, we have the Chief Operating Officer of Orthopedic Analysis, Dr. Marco Caicedo, with us, and he is going to talk to us about innate and adaptive immune responses in regards to metal hypersensitivity and all the things. Dr. Caicedo, we're so excited to have you here.
Thank you so much, Sherry. I'm really excited. I think what you're doing is great and excited to share some knowledge and hopefully ask any questions that you or your followers may have. We're ready to go.
I've got some questions from them, so I'm super excited. I don't always get questions, but I had questions today. So we'll get those probably closer to the end. But I want to tell everybody a little bit about your background. I'm fangirling over here. I can't believe I'm so lucky to have you on. He is the Chief Operating Officer and Senior Scientist for Orthopedic Analysis, an adjunct assistant professor for the Department of Orthopedic Surgery at Rush University Medical Center, PhD in Immunology from Rush University, a Bachelor of Science in Biological Sciences from the University of Illinois, postdoctoral fellow specializing in investigation of immunological responses to orthopedic implants, winner of many medical awards for work in orthopedic research and research excellence, author of numerous PubMed and journal articles, and a reviewer for the Journal of Orthopedic Surgery. Did I get that right?
Yes, I think all of it is correct.
Awesome. Feel free right now to tell us a little bit more about your history and background. And I really want to know who makes you, Marco. What do you do for hobbies and fun as well? Like what your family life is like.
Sure, absolutely. So a little bit about my background. As you mentioned, I got my bachelor's in science at the University of Illinois in Chicago. After I finished that, my senior year of college, I was fortunate enough to get some sort of internship in Dr. Halab's lab. It was a biomaterials lab at Rush University Medical Center in the Department of Orthopedics. And that's where I was first exposed to what it is to look into immunological responses to biomaterials. I never really thought that that was possible. Everybody thought of metals or things that are not biological as being inert in your body. So they were looking into that, and I quickly became fascinated with it. So soon after I graduated, I was able to actually get a job in the same lab as a science tech, and we continued to do some of those projects, and I really just fell in love with it. I thought that this was a great career choice, if possible, if I could study these further. So I looked into the possibility of joining the immunology department and go to grad school at Rush University. And thankfully, they allowed me to work on this project for my PhD dissertation. So fast forward 5 years after that, I was able to get my PhD in immunology, working specifically on immune responses to biomaterials. Like I said, it was a topic that fascinated me. I fell in love with it. I'm still in love with it. And that's the reason why I'm here at Orthopedic Analysis. We've been doing these for 15 years now. And hopefully we have many more years to go, and we keep growing as we have in the last few years. Now, personally, I have two kids. I have a 15-year-old, a sophomore in high school. I have a 12-year-old going on 17. They keep us busy. My wife and I have pretty busy schedules with our kids, but family life, wouldn't trade it for the world. Our kids are both competitive swimmers, so there's a lot of swim meets in between, a lot of school, and I guess it's a personal hobby. I like to play basketball. I like to read quite a bit, and that's really what makes me. It is really immunology, biomaterials, family, basketball. there you have it.
That's awesome. Okay. Do you watch competitive sports?
But randomly here and there, when there's time for it, yes. Yeah, absolutely.
Doesn't sound like there's a lot of time left on the radar. How did you get to be the chief operating officer of orthopedic analysis?
I was doing my PhD at Rush. Basically, the whole project was really working on innate and adaptive immune responses to biomaterials. While these was occurring, orthopedic analysis was already being established. There were many surgeons that have heard of these research tests called the LTT for metals, and there was a lot of inquiry about doing that. Right at the time that I was graduating, it was decided that orthopedic analysis will become an independent company to try to provide these service in a better way to surgeons and patients that needed it. It was very difficult to do it as a research laboratory. We really wanted to facilitate these to patients and doctors, and the only way to do that was to make it an independent spin-off, basically, where we can really market it and provide kits and make it easy for surgeons and patients to do it. So I was fortunate to be at the right place at the right time. I had the experience on the test. So it was scary, very scary at the time. Thankfully, things have progressed really well. Fast forward 15 years, and here we are.
Awesome.
Yeah.
Could you explain the significance of metal allergy in the context of implant degradation and its impact on patients?
Oh my goodness, where do we start? We have about 10 hours. As I mentioned before, the idea that biomaterials could induce an immune response was not really well accepted in the past. Even me starting in grad school is very difficult. I was still at the intersection between immunologists and orthopedic surgeons, where immunologists couldn't care less about metal sensitivity because they're dealing with HIV, they're dealing with crazy viruses. They're like, really, nickel allergy, is that really what you're worried about? Orthopedic surgeons are worried about knee replacements and hip replacements. Didn't really care about biological responses. So the impact is huge. Once we were able to establish, not only us, but there have been, many, many groups around the world that have established that you can actually induce an immune response after exposure to different degradation products, whether they are metal particles or metal ions that come off the implant. Obviously, that is going to induce an inflammatory response. And that inflammatory response is going to be different on everybody, because you will have first an innate inflammatory response, which is non-specific. So whether you are sensitive or not, it doesn't matter. Your macrophages, which are the innate cells of the immune system, are going to pick up those corrosion products and they're going to respond. In some people, that'll be a mild response. In some other people, that'll be a tougher response, a more inflammatory response.
And that makes sense because our bodies are intelligent and the immune system just sees it as something that's not supposed to be there, right? Exactly. It's doing what it's supposed to do.
It's doing what it's supposed to do. And one way that I like looking at it, and the way that I explain it to a lot of people, is that you have to think of your immune system as an army, where you have foot soldiers, where you have your snipers, where you have your special operations team, your generals, etc. So when you have an issue that is not that big of an issue, maybe your foot soldiers will take care of it. There's no need for anything else. There's no need to send in your SWAT team to deal with a simple robbery somewhere, correct? Now, if you have a hostage situation or you have a robbery that involves 100 people, well, now you're sending in more troops. You're sending in your SWAT team, your snipers, you're sending in generals, you're sending in a lot more complex cells that are able to deal with that. So again, when it comes to biomaterials and orthopedic devices, it really is going to depend on how much corrosion, how much wear is being released from that implant, and how primed your immune system is to respond to that. And what we see in people is just a huge range. So the first level of reactivity is going to be innate, where macrophages are going to find these particles or they're going to be exposed to ions, and they will induce an inflammatory response. Now, maybe this is just a very small amount of metal, and maybe it stays at that. It's just a very low grade pro-inflammatory response that likely will not lead to anything detrimental clinically, right?
Right.
Maybe over time, you do 5 years of these, 10 years of these, 20 years of these, that may be the reason why implants eventually fail, right? Because your bone balance during these inflammatory response is going to basically give way to that implant to get loose. But that's the best case scenario. Now, in the worst case scenario, now you have people that may be sensitive, and then you still have these macrophages or innate cells that are picking up these antigens, and they're saying, hey, this is not good. There's a lot of debris here. I am going to send all of these alarm signals out there to get more immune cells to fight these off because your immune system thinks that these should not be in your body, right? And that's what it's supposed to do. Because if
Right.
you get infected with bacteria or a virus, it wants to clear it, it wants to kill it. Now, the big problem is that you're not going to clear a big piece of metal in your hip or your knee or your spine, right?
Right.
And that becomes a problem. So all of these signals get sent out, and now you have more specialized cells like your lymphocytes, your T cells, which there are many different kinds of cells. And they're going to come in and they're going to say, like, holy, this is not good. Okay, so let's just start a higher inflammatory response. We're going to recruit more macrophages. We're going to recruit more lymphocytes because we need to get rid of this. Obviously, you cannot get rid of it. So you have this vicious cycle of inflammation, right?
Yes.
That in some people really becomes extremely painful, obviously. So I think that is the reason why not only metal sensitivity in the sense of a metal allergy or an adaptive immune response can potentially induce clinical symptoms and clinical issues in people with either orthopedic devices or any biomaterial in their body. Even just your innate response or your toxic response to those types of metals and particles would induce an inflammatory response and can also be detrimental without specifically having to be an allergy. Allergy basically is the worst case scenario immunologically in that sense.
That's interesting that you bring that up. Briefly, what's the difference between allergy and that type of inflammatory immune response? What's the differentiating factor there?
This is a great question and something that has been extremely difficult to explain or have people understand because everybody understands allergy as basically the one immune response that we all get, right? If you have seasonal allergies, you call it an allergy. If you have a peanut allergy, you call it an allergy. If you have dermatitis because of poison ivy, you call it an allergy, right? There are many different types of hypersensitivities or immune responses in general. Not everything is an allergy. So when it comes to hypersensitivities, you have hypersensitivity type 1, type 2, type 3, and type 4. We look at hypersensitivity type 4, which is a delayed type hypersensitivity, which is what we can see happens with different metal haptens like nickel or cobalt or chromium, right?
And is that an allergy?
You can consider that an allergy, right? It's a delayed type hypersensitivity response because people, have dermatitis and they consider that an allergy, right? It's a hypersensitivity. Okay. So allergy is a tough word to put everything under that umbrella. Now, when you get vaccinated for any type of vaccine, what you're inducing is a delayed type 4 hypersensitivity. You're getting all of your immune cells out there. Now, is that an allergy? No, it's not an allergy. It's an immune response. That's what your immune system is supposed to do. You receive the antigen in your arm. Now, this brand new antigen is there. So what happens now? Your immune system, your blood immune cells are going to rush to it. You're going to have those macrophages, monocytes, dendritic cells pick up that antigen, and they're going to present that to the generals of the immune system, which are your T cells, your lymphocytes. They're going to recognize it as something new. They're going to say, holy cow, this is not supposed to be here. This is new. We don't know what it is. Attack. Let's just start an immune response to get rid of these. So lymphocytes proliferate, and that's exactly what we look in our test orthopedic analysis. And when they proliferate, some of those lymphocytes become effector lymphocytes, meaning they become cells that are immediately going to attack that new antigen they just found. Mm-hmm. And some of them become memory lymphocytes, which will stay in your body for a very long period of time. That's the whole point of a vaccine. The point of a vaccine is that you have that memory so that next time you get that antigen, whatever you were vaccinated against, you already have generals that know exactly what to do when they see it. Mm-hmm. So therefore, you induce a very strong and potent and quick immune response so that you don't get sick. Okay. So again, allergy is a word that is thrown out there for everything, but that's how most people understand an immune response. Certain things are allergies, certain things are not.
So in regards to implants and foreign bodies, when is it considered only an immune response and when is it considered an allergy?
It's a very good question. I truly think that allergy may not be the correct word for an immune response to an orthopedic device because
let me throw something at you. This is going down a rabbit trail for a minute. But in my particular case, I'm going to call it a metal allergy. When we knew that I had a metal allergy, we drew serum blood histamine labs. My blood histamine labs were 3.53. The range was to 1. So 3.53 is off the chart. I go in and have a revision to a lumbar fusion surgery. They take out 10 of 13 pieces of lumbar fusion hardware. Within 3 weeks, my blood histamine level was at the lowest end of normal. So 0.016. So I would say, I'm a layperson, but is histamine a deciding factor? I have a lot of histamine. We remove metal and I don't have the histamine. That's an allergy,
I agree.
right?
What you're describing is basically is that hypersensitivity type 1, right? Hypersensitivity type 1 is going to be sensitivity that is going to be mediated by IgE antibodies, release of histamine from different types of immune cells. That is very widely considered a type of allergy. But
Can
it's
you have
also
type 1 and type 4 with metal at the same time?
I love that question because this is the thing about immunology. Immunology and your immune response can be very redundant. Everybody tries to label everything. It's like, oh, type 1, type 2, type 3, type 4. And that's fine. We know these different types. And in certain circumstances, yes, they're very defined, but not always. Sometimes they overlap. Sometimes people can have a little bit of both, or skew to one side or skew to the other side. Just to give you an example, so a peanut allergy, that's a classic type 1 hypersensitivity where immediately you start feeling the effects of your throat closing up, hives, all of these effects that happen pretty much soon after you consume it if you are highly sensitive. If we get to have a peanut allergic individual and we test that for a delayed type 4 hypersensitivity, a lot of them also show a response in a delayed type 4 hypersensitivity. So there's this redundancy in your immune system. And one extra concept that I think is extremely important to understand, and I try to put it out there as much as I can. When it comes to your immune system, it is like real estate. And I know you are a real estate agent, right? Location, location, location.
Okay.
Let's go back to our analogy of your immune system being an army. You need to understand your immune system is smart. It understands where it needs to go in with the big guns or where it needs to go in quietly in a different way. You are not going to have the same immune response in your eye if you have an infection in your eye as you would if you have it in your blood or somewhere else in your body. Why? Because you don't want to induce that collateral damage of a DTH response in your eye and then kill off the adjacent tissue.
Right.
And basically cause more harm than good. Same story with a lot of people have heard of immunoprivileged tissues or immunoprivileged organs, where previously it was thought that, well, your eye, your brain, testicles, they are considered immunoprivileged, meaning that they don't really have an immune response because they're so sensitive. And basically, it's not correct. It's not that they're immunoprivileged. They just have a different type of immune response where other cells are involved as opposed to a DTH response. So if you have an infection in your eye, you're going to have more of an antibody response as opposed to a cell-mediated response because you don't want to induce collateral damage. So that's hugely important to understand.
Okay, man, so many questions. I would just say, I think I definitely from experience have both a type 1 and a type 4 because I eat high nickel foods and I do react to them, but it's not immediate. It's 4 to 6 hours later. So I think I definitely have both reactions. And that's kind of crazy. I didn't even know that that was a thing, but it only makes sense. How has your background in immunology influenced your approach to understanding and addressing systemic metal allergies?
We have not had the ability to address systemic metal allergies as much as we have local induced immune reactions around implants, because the percentage of people that we have access to or that come to us, the vast majority are individuals that do have localized pain, localized responses to their orthopedic device, whether it's a hip or whether it is a knee. I think that the percentage of people that come to us with systemic symptoms of metal allergy is pretty low, surprisingly.
Really? I
Yes.
am blown away because
Yes.
I would probably say 100% of my listeners are systemic reactions.
Yeah, right. So what does that tell you? That there are way more people out there that probably don't have a systemic reaction, but have a localized response. And the problem here is that many of them don't know that it could potentially be caused by an immune response. It's just painful. It's been only 6 months since your surgery, only a year, give it time, which in a lot of cases is true. It does take time for a person to feel better after surgery. But again, a lot of patients just don't know, and a lot of physicians don't know that these can potentially be caused by an exacerbated immune response localized around the implant. So again, definitely the majority of people that at least I have been able to speak to tend to be people that have localized immune responses to their implant. But at the same time, we have had, and we do on a weekly basis, see also people that have systemic symptoms of metal allergy. It's hard to study that. And the reason for that is that the symptoms vary wildly between people. We go from rashes in different parts of the body, hair loss, fatigue. So the whole gamut is out there, and it's difficult to pinpoint exactly what's going on.
So I have a list of symptoms, and I think there's 50 some odd symptoms on that list. I had all but 5. I had cardiac symptoms. I had hair loss. I had autonomic nervous system dysfunction. I had, at one point in my journey, 35 specialists. I had a specialist for everything. Kidney, heart, you name it.
Yeah.
I had every symptom.
I believe you, and I agree. There's still a lot that we don't know, especially when it comes to systemic sensitivities to metal allergies. Here's something that I think you may find interesting and your listeners may find interesting. So the way that your immune system works, cells communicate with each other, and they communicate by sending signals. And in the world of immunology, a lot of these signals are proteins, and they're called IL-1, IL-2, IL-4, IL-5, IL-17. Each one of those proteins affects other cells to do different things. So if I want a specific lymphocyte to be more of an antibody type of response to an antigen, then signals are sent to that lymphocyte like IL-4, IL-5. If I want the lymphocyte to be more of a cytotoxic type of response, then IFN gamma, IL-6 would be the signal. So there are many different signals in which these cells communicate, and this is all in the immune system. So now the same signals that the immune system uses to communicate with each other, with its own cells, they also produce certain neurotransmitters that can actually communicate with your nervous system. And your nervous system also produces signals that allows those cells to communicate with each other, which are called neurotransmitters. Your immune cells have receptors for neurotransmitters, meaning that your nervous system has the ability, obviously, not to communicate with itself, but has the ability to communicate with your immune system. So we're talking about the field of neuroimmunology, which I'm sure is out there, right? Exactly. Mind blown. That's what we know so little, because there's so much to know. There's so much to learn that we still don't quite understand. We are able to see how our immune system in a dish responds to different antigens. How awesome would it be if we could have also some nerve cells underneath that to see how that affects communication or how the immune system affects those nerve cells? But we're obviously limited. We cannot do that.
Okay, here's an immunology question, and this just came to me on the spur of the moment, so forgive me if it's scattered. Is there a way to take a patient, such as me, use me for an example, that's reactive, and measure which of those neuro cells are reacting, which are hyperactive?
But it's impossible to do. Your neurons are basically there for you for life. They're not the type of cell that proliferates, and that's the reason why when you have a spinal cord injury, if it's severe enough, that's it, you're done. You cannot get those back. On the other hand, your immune cells, they replenish every once in a while. Depending on what cell it is, they are always being replenished. So it's easier to work with them. It's easier to collect them. We cannot test your nerve cells. We can theoretically see how much of a specific neurotransmitter you have circulating through your body. And we could potentially measure how much of a neurotransmitter your immune cells are producing, if that's the case. It's not going to be a lot, but it's been shown that it can be done. So yeah, there's a difficulty when it comes to that. Doing multicultural systems, it becomes really hard.
Got it. If you had all day and multiple years with doing nothing else, perhaps we could get there in that research, but probably not there yet. Can you share some insights into key challenges and advancements in the field of metal hypersensitivity and allergy testing over the decades?
We are it. Here's what I think is the key advancement that we've had in the field of metal sensitivity. If we go back 15, 20 years ago, I think there was a huge percentage of people, both healthcare providers and patients, that really did not believe that this was a thing. To the day, we have people that believe that metal allergy does not exist, that it's made up. Or if you have a
And they
little
dare to
rash,
tell a PhD that it doesn't exist.
trust me, I haven't seen it all, but I've seen a lot of weird things out there. I've heard a lot of weird things from both patients and physicians. And like I said, vast majority of surgeons and patients and physicians that we deal with, they mean well. There's just a lot of information that they don't know how to deal with it, in my opinion. But I think let's go back 15, 20 years. I feel that metal sensitivity when it comes to orthopedic devices was not considered a thing. It was like, no, that doesn't happen, period. It was not on anybody's radar. I think that the work that a lot of people have done, including ourselves, and really looking at the basic science and explaining, look, we can see it through many different experiments that all of your immune cells are responding in different ways to metal particles and other challenge agents. It's a real thing. And I think over time, fast forward 15 years or so, it's pretty widely acknowledged now that this is a phenomenon that occurs in people. We can disagree in how many people it happens. We can disagree as to how detrimental these phenomena may be to an orthopedic device. But what we cannot disagree with is that it exists. And that has been now published by the FDA. The FDA had a huge meeting in 2019 where they published a 175-page document titled Biological Responses to Metal Implants, where they list absolutely everything that is known. I think that has been the main advancement that we've made in metal sensitivity, at least the acknowledgement that this is a real phenomena that occurs in some people. And even though testing is not going to give you a yes or no answer, it's going to give you an answer that the patient is metal sensitive. Therefore, that patient may be at a higher risk for implant failure or other type of systemic reactions to that implant.
What role does research and academia play in your work at Rush in advancing the understanding of systemic metal allergies?
A lot. I think that's really what sets us apart. Dr. Halab, he's a scientist, he's a professor. I consider myself as well a scientist. We're not business people. Orthopedic analysis became orthopedic analysis not because of our marketing savvy and talking to people or anything like that. Orthopedic analysis became what it is because of all the publications that have come out in the last 20, 25 years. All the conferences that we have gone to speak to surgeons here and abroad. And it's been basically word of mouth, where they have been able to see the basic science, they have been able to see the clinical studies and make their own determination and say, yeah, this is real. So to us, continuous research is extremely important because that's really what shows and educates physicians on the topic. We have been transparent all the way. At least a couple times per year, we publish what we find. We try to go to conferences. And I know that sometimes it becomes difficult. There's a lot of politics involved where wherever we submit our science, it may not be well taken because it may not be something that they want to hear. But nonetheless, it always gets published somewhere. It always goes somewhere where we can actually talk to an audience of physicians and patients about the topic.
How do you see the landscape of metal allergies evolving in the future with the increasing use of various metals in medical devices?
I think it's going to grow quite a bit. Implant companies have great products. They have really improved the quality of life of millions of people, right? But again, there's the percentage of them, which is the percentage that we work with, that it has been very detrimental to them. There is a way of preventing these or reducing the risk of that. We're not going to have less metal devices in the future. We're going to have more. There's going to be more joints, more hips, more knees, more spine, more cardiac devices, more staples. And the 10 to 15% of the population that is allergic is going to continue to be a 10 to 15% of the population, if not more. Metal sensitivity is going to be a topic that is going to be increasingly known by people, by patients, obviously providing an ability for them to accurately test is going to be of utmost importance in the future. So I have a pretty optimistic view of what's going to happen in terms of physicians understanding the topic, which I already see a difference. The new generation understands it. The new generation is starting to include questionnaires for patients, letting them know what they are going to get, what the risks are. The FDA is on it. It's a possibility that they may require physicians to go through a questionnaire with patients to, at the very least, explain the risks and hopefully have them test patients that are concerned about it or patients that have a history of metal allergy. Is moving in the right direction. It's just moving very, very slowly.
What strategies do you see that are promising as far as mitigating metal allergies and implant degradations? What technologies do you see coming down the pipeline that are going to assist with that?
Well, we know that the most reactive metals tend to be nickel, cobalt, and chromium. I think virtually most implant companies at the moment have devices that are quote unquote alternative materials, where they either have alloys that don't contain those sensitive metals, or they have coatings around their implant that basically hide the potential sensitive metals. So I think we're going to see a little bit more of that. I really do think that as more people become aware of the issue and more people either tell their surgeons ahead of surgery, hey, I cannot wear jewelry, I have a history of metal sensitivity, my mom, my sister have a history of metal sensitivity. As more of that comes into play and they get tested as well, I think surgeons will be more likely to start using alternative devices, which in theory should start reducing the number of people that respond to metal allergies. Now, in terms of procedures to reduce inflammation in people that already have devices, I think that may take a little longer. I think we actually already have the medications and the drugs that can actually help. All the same drugs that you use for rheumatoid arthritis, for other autoimmune diseases, all of those drugs can potentially be helpful also in an inflammatory response to implants.
That was mind-blowing to me. I felt like I knew everything and I was at maximum improvement and I was just going to live on antihistamines the rest of my life. I had never considered rheumatology drugs.
You cannot watch TV for more than a couple of hours without seeing commercials for biologics. Biologics are drugs that are basically antibodies that bind to the signals that your immune system uses to communicate with other cells. I mentioned before, you have a cell that wants to bring in more inflammation, so it would produce TNF alpha, that's one of the proteins, for example, which would bring more cells for more inflammation. Now, there are commercially available drugs out there like Humira or Remicade. I don't know if you're familiar with those or not.
I am.
All of those medications, they're nothing more than antibodies that bind to those signals. So if you're blocking TNF, which is one of the signals that your immune cells use to bring more inflammation, you're blocking that, which means that you're not generating that much more inflammation anymore. You feel better. You're dumbing down your immune response, right? Now, technically, theoretically, if you are creating that same type of inflammation because of wear debris from an implant, and you're producing those same inflammatory mediators like TNF, IL-6, IL-1, and there are medications out there that block those. In theory, you should be able to reduce that level of inflammation and hopefully make the patient feel better.
Well, that's incredible news for not just people that have to live with a lot of metal in their body like me, but somebody like me is in a really delicate position. If I ever have to have a pacemaker or a cardiac stent, or God forbid, I'm in a car accident and I have to have some other implant surgery, I would tell you right now to just let me die. But the possibility of a medication that could actually manage the systemic inflammation and give quality of life in that unfortunate circumstance gives hope to so many people, because maybe the future isn't as dire as it seems like it could be for somebody.
Yeah, absolutely. I truly believe in that. Now, the key here is like, how would you get that approved? You would need to do studies where you have thousands of people that basically are going through the same type of inflammatory event due to metal in their body and see which one of these medications would actually work with these individuals. And like I said, everybody is different. Your immune response to metals may be different than your friend's immune response to metals. So Remicade can potentially work for you, but it may not work for the other one. So then it becomes very complex and very messy very fast. But in theory, there are agents out there that can help.
Are the metal allergic patients going to then have a battle with their rheumatologist getting these drugs approved for this type of use?
Absolutely. They would have to use it as an off-label medication, and you're going now into uncharted territory. When it comes to science and immunology, we have a lot of tools, and that's my fascination with the immune system. The holy grail in a lot of the scientific groups is now trying to figure out how we can make organoids to see how that organoid responds to different things. So people are trying to make
organoid.
Exactly. So let me get to that. So they're trying to basically artificially create like a tiny little liver, for example, that you could put in a petri dish or that would resemble a liver as much as possible, right? So that you can see how that organoid will respond to different things. You want to create a cardiac organoid. You want to create a liver organoid. You can create a renal organoid. And it's extremely difficult. People have been trying to do these for many decades. And the advancement is there. They're getting pretty good at it. Now, when it comes to the immune system, I think it's one of the few systems where we just need a blood draw. And from a blood draw in a blood tube, you contain all of the immune cells, the same immune cells that you would have circulating through all of your body. So it is technically not an organoid, but the easy access we have to it, it's crazy awesome for us because we are able to actually see what your immune system can or cannot do. You cannot do that with your heart. I cannot tell you like, oh, your cardiac cells are doing these or are doing that. You can't do that. They're in your heart, and we just don't have the ability to do that. We cannot tell you, hey, I treated your liver cells with these agent, and they're doing these, right? Your immune system is the one system where we can actually isolate from a simple blood draw, and we can really see what it's doing. And granted, again, I said location, location, location. Just because your immune system is doing something in a petri dish, it does not necessarily mean that it's doing the same thing all over your body, but it's a pretty darn good proxy, especially when it comes to sensitivities and allergies, etc. So that's something that we need to take advantage of. That's something that we are taking advantage of. And I think it's just going to get bigger.
Okay. Can you share any patient stories that highlight the real world impact of identifying and addressing systemic metal allergies?
Well, there's a few stories, very similar stories to yours, where we have patients calling us where they have gotten a specific type of device. And after they receive their device, they have experienced dermatitis, hair loss, fatigue, and they're diagnosed with a positive metal sensitivity test for nickel or whatever metal they're allergic to. And obviously, nothing goes away until the implant goes out. Once they report back to us that they went to revision surgery and their implant was swapped with something that was more hypoallergenic or did not contain the offending metals that the patient was reactive to, that's when they felt better. So you have the same anecdotal cases that your guests on your podcast have described in the past. It's the same thing that we hear here, not only for systemic metal sensitivity, but even for localized metal sensitivity when it comes to inflammation and pain and effusions from the implant. I've heard some pretty bad stories where a patient has gone in for their first surgery, obviously is not doing well because of a possible metal allergy. Then it goes back to the surgeon. And again, the surgeon at this point, they didn't know that a metal sensitivity was a possibility, right? So immediately they just assigned the pain and everything to, I don't know, maybe there's something mechanically wrong that we cannot catch on the x-ray or the MRI. So they go back in for revision surgery. They swap the implant for the same exact type of implant. They just try to make sure that it's mechanically sound. And a few months later, same problems, same issues, pain, inflammation, right? Effusions. And not until they go to a second revision surgery where they now found out that the patient may be metal sensitive and they swapped it for a hypoallergenic type of component, did the patient feel better. So I think communication is extremely important.
I've got a listener right now. I think she's had 1 or 2 revisions on a knee and has not been able to tolerate anything to where they've had to pull it out. She just has a spacer and she has not been able to find anything to go back with because every stem that's going to go in is metal.
Has she been tested for metal sensitivity?
Yep. She's
and
off the
allergic
chart
to
for
many.
nickel.
Yeah, and this is actually, I'm glad you're bringing these up because this is also very important.
And she's sitting there with a spacer. I mean, what's she supposed to do?
Yeah, that's tough. And unfortunately, I have to tell these to a lot of patients and physicians when they call us, is that unfortunately there's a limitation because all of these things are metal. And there may be people that are so extremely sensitive to things that they don't necessarily need to show a sensitivity to all of the metals in the alloy. Being extremely sensitive to nickel is a pretty good indication that your immune system just does not like metals in general. Let me expand on that a little bit. There is such a thing as cross reactivity, and this has been shown very clearly in animal models. In order to be hypersensitive to something, you first need to have the initial challenge when you become sensitized. And then you have the second exposure when your immune system really just goes haywire. The same concept with vaccine. You have your initial exposure, and then when you get the real thing, then your immune system kicks in and fights, right? In animal models, they have been able to basically go with the initial challenge with nickel. So you sensitize the mouse to nickel. And then for the second challenge, you don't use nickel. You use cobalt or you use chromium or any other metal. And then they respond to that metal as if they were initially sensitized to that metal. So cross reactivity is a very real thing that we, again, don't understand very well yet. But I would not be surprised one bit that patients that are very nickel sensitive may be responding in vivo to other metals that are not nickel.
So what do you do when you got to have a knee and
That's
you can't have one?
That is a very difficult situation to be in.
And there's nothing there. There's nothing in there
because virtually every implant is going to have some level of metal in one of the components. I mean, there are ceramic components which basically don't have any metal. I don't know every component out there. There may be a fully ceramic knee, but yeah, it becomes very difficult because virtually all implants are going to have some sort of metal component somewhere in the device.
Then you would hope you could treat with the rheumatology drugs, but if that's going to be a battle,
that's going to be more than a battle.
Answer.
I cannot even imagine what it would take for FDA or whatever organization to approve that. I am pretty sure there would have to be many studies to prove that that works.
Oh man, you gave me hope and then you took it away.
That's our life. It's so difficult to deal with everything that comes into it, all the regulations, all the possibilities, especially when you know that there's a lot of things that we can do. But in order for us to be able to use them, all of the necessary studies and all of the necessary due diligence needs to be done before anybody can use it. So it becomes complicated. Right.
Okay, I've read in some of your literature that you talk about inflammasome danger signaling. Can you explain what that is and how that works?
Absolutely. I am a huge fan of a scientist. She's an immunologist. I'm pretty sure she's still around. And she was one of the very first ones, if not the first one, to come up with a theory that said that in order to induce an immune response, you not only need to have a foreign antigen, something that is not supposed to be inside your body, but you also need a danger signal, right? Now imagine our gut is full of bacteria. Why are we not attacking that bacteria? Why is our immune system totally cool with our bacteria just hanging around our intestines, where 80% of our immune system is in our gut? They're living happily together, right? Commensal bacteria. So her theory was that nothing happens because there's no danger signal. Your immune system recognizes the bacteria. They're like, okay, it's a good guy. Nothing bad is really happening here. Now, when there's a virus or a bacteria that is actually killing your cells are going to release danger-associated signals, meaning that your immune system, again, is so smart that if a cell is killed by a virus or bacteria, all of these danger signals are going to be released. Now you have the recognition of a virus from your T cell for a virus and the danger signals showing you there's something dangerous happening over here. That was her theory. I found it fascinating. I think it has changed immunology quite a bit. So when I saw that with Dr. Halab at Rush, we talked about it. We're like, well, I bet you that metal ions, because they tend to be toxic as well, I bet you that those are inducing danger signals. So that's basically my whole PhD dissertation. That was the project that we really dove into.
Are those cells measurable?
Well, the danger signals are measurable. Every cell has the ability to do it. So specifically macrophages. That was the link for people to understand why non-biological agents can induce an immune response.
Okay.
The thought before was like, you can only recognize biological agents. You can only recognize a virus or bacteria or fungus, right? How can you recognize a metal particle? So what we saw and what we published is that when macrophages ingest a particle, and particles are not going to be these beautiful round little things. They're going to be jagged. They're going to be different sizes. They're going to be crazy looking. When macrophages ingest that, automatically the compartment inside the cell that is supposed to keep that in place, it kind of just breaks and it spills all of these molecules and signals that are your danger signals. That is called the inflammasome complex. And because you basically activate these pathway in your macrophage immediately starts sending signals to other cells saying like, we got danger over here. We need to attack these. This is not good. And then lymphocytes come into play and you can induce an adaptive immune response to it if you are sensitive to the metal. And that was huge. It was really the connection between why inert or non-biological substances can induce a response. So the inflammasome danger signal was really one of the reasons why.
Are there any additional research findings and breakthroughs that have enhanced the understanding of how the immune system interacts with metal implants?
I think that there are a lot of groups around the world that are working on these. There are certain groups that have come up with other specific molecules that are involved in your immune system responding to metal debris. I think at the end of the day, the big picture is always going to be your adaptive immune response and how that is recognizing metals and how those T cells proliferate and induce inflammation. But there's a lot of research, I think, that is being done trying to describe that better at the molecular level, which is very interesting. It may not be interesting to just a regular person, but in terms of basic science, it's pretty fascinating. I think that that's as far as we can go. I think right now, the challenge and the race that we are in and many groups are in is trying to correlate, trying to show what the effect of an adaptive immune response to metal implants is to your clinical outcome when it comes to a metal device. And it's not easy, it's complicated, but that's why we're here.
Okay. In the case of metal allergies, are there instances where the immune response targets both the metal components and the surrounding tissue? And how would the dual response impact patient outcomes?
Yeah, a DTH response is not a response that is subtle. There's a lot of collateral damage. So when you induce a DTH response is almost, I don't want to say it's your last resort response, but you're
That's a
bringing
delayed
in
type hypersensitivity response, just for people who don't understand.
Correct. Yeah. So you're going to have the big guns coming in, which are your T cells, both CD4s and CD8s, which are specific types of T cells. And unfortunately, there's going to be some collateral damage. So if you have nickel ions or particles that are all around your tissue and your immune system is responding to all of that, they may recognize those cells as cells that need to be destroyed, just like as if they were infected by a virus. So there will be a lot of collateral damage. It's not just trying to get rid of the specific particle. They are going to induce quite a bit of damage to the tissue around it for sure.
You know, and that's interesting. When I had my implants removed, in almost every instance, the surgeons had said they didn't see a lot of reactivity in the tissues surrounding the implant. Would that be common or uncommon?
Yeah,
given how severe my situation is.
It sounds like your type of reactivity was more of a hypersensitivity type 1, right? Where there's a lot of histamine, there was a lot more of an allergic IgE type of response to the metal that you have in your body.
And so yet I do have the systemic type 4 because I've seen it with my diet.
Possible. So again, it's a very dynamic and interchangeable type of response. I really don't have the answer why you wouldn't find a lot of tissue damage. Maybe it's just the severity. And that's, again, something really important when it comes to hypersensitivity, whether it's type 1 or type 4 or type 3 and 2. There is going to be a severity range, right? You cannot, and again, that's why I really try to stay away from saying like, oh, the patient is sensitive or is not sensitive. And that's the reason we have a range of reactivity in our results, because it matters a lot. For somebody that is at a 25 SI, that is different than being at a 4 SI, right? Both may induce clinical symptoms, but the 25 SI may really cause a lot of tissue damage. The forest side may or may not, there's going to be a range of severity, and that is important for people to also understand.
I could have a huge type 1 reaction that is very clinically significant and still a type 4 reaction that's very mild, still significant, but mild enough to not affect a lot of tissue damage. And it's all just part of my unique clinical picture.
Absolutely. Okay. Everybody's immune profile is going to be different. Your initial immune response to any challenge agent is going to determine what type of response you want to go to, and depending on where it happens. Again, the severity is going to be variable and really important to understand the clinical outcome because of that severity.
Gotcha. And now, a word from our sponsor. Attention metalheads, are you struggling with skin rashes, joint and systemic pain, or fatigue that just won't go away? Type 4 metal allergy is often overlooked as a culprit in many of today's chronic illnesses. Get to the root of the problem with ELISA testing. ELISA is a scientifically proven and clinically validated test that measures immune reactivity to metal allergens like nickel, cobalt, and titanium. With fast and reliable results, you can get the answers you need to find relief and live a healthier life. Don't let metal allergies control your life any longer. Visit melisa.org to learn more and schedule your test. Trust us, you'll be glad you did. MELISA, a valuable diagnostic tool in medicine. Are there certain patient profiles or genetic factors that could predispose individuals to developing metal allergies after implantation?
Yes, I believe so. I think we need to be careful with genetics. Just because you are predisposed to something does not necessarily mean that it's going to happen, right?
Correct. The gene doesn't always turn on.
Exactly. The environment is going to be also very important. But yeah, I think it's very common for me to hear from individuals that not only they have a history of metal allergy, but the sister has it, the mom has it, the dad has it. So there seems to be a genetic component for your immune system to be more able to recognize certain haptens, whether they're drugs or metals. I don't think it has been 100% proven, but there's definitely something there. Again, just being genetically predisposed to something does not necessarily mean that it's going to happen later on. So you need the environment as well as the genetics for it.
What genetic predispositions would there be? Can you cite some specific ones that might predispose somebody to metal allergy?
There are certain receptors on all of our T cells, lymphocytes that we have in our blood, have receptors for different antigens. And all of these receptors have different proteins as well within the receptor. The receptors are proteins. So there may be a genetic predisposition for some people to have T cells that have receptors that are more able to detect certain things, like haptens, whether there are drugs or metals or any other antigens. Just like there may be genetic predispositions for people to have T cells with receptors that are so good that when you actually catch a virus or bacteria, they're going to induce an immune response that is too potent. It's just too much, right? Same thing for autoimmune disease, right? It's also probably a genetic predisposition where your immune system is just a little too crazy that is starting to detect things that it's not supposed to detect because they're your own tissues. It's not supposed to attack them. So there could be a genetic predisposition for that. There's a whole gamut of,
do we have a list of genes
for metal allergies? Not that I know of.
That would be cool to have on the orthopedic analysis website. Here's a list of genes that you might have that could predispose you. Or is that ground too sticky?
I don't think it would be helpful. I think having any gene that we may think is associated with metal allergy, it will be interesting to know, but I will be very careful to use that as a method of diagnostic of what can happen in vivo.
Slippery slope.
There's a lot that happens in between. It's the amount of immunomodulation that occurs in your immune system, it's insane. To the point that not only do you regulate the genes, you can even regulate the proteins. You can actually make an inflammatory protein in your cell that is ready to go. And there are immunomodulation pathways where they will block that. They'll be like, yeah, actually, we don't need that protein, right? So there's regulation at the gene level, there's regulation at the protein level, and even better, there's regulation at the cellular level. So here's something that a lot of people don't know. I keep talking about lymphocytes and T cells, which are the generals and the ones that induce this response, right?
Yeah.
So there is this population of T regulatory cells, okay? And these are also
Okay.
T cells. But those guys, in the sense of an army, are more of the negotiators, right? Their job is the opposite. They are supposed to bring the immune response down, right? It's a feedback loop mechanism where you have initiated an immune response, and these guys come in and they're like, that's enough, guys. We now want to induce more
I
inflammation
must be
because
pretty low on those dudes.
you know what? Not a lot of people think about these guys, and I can guarantee you that there's a lot of pathologies that are likely directly correlated with how those guys are doing their job or not. It's crazy important. So you even have that level of regulation from gene to protein to cells, where there's always going to be something that is going to stop the response if it needs to be stopped. Going back to location for your immune system, right? Why an immune response in your skin is not going to be the same immune response inside your body or in your blood. So your skin, we're constantly exposed to bacteria, to viruses, to a lot of different things. Your immune cells in your skin are likely to have about 15 to 20% T regulatory cells out of the total percentage of lymphocytes. Your blood, we're talking about less than 5%.
Okay.
It makes sense because if we did not have that level of regulation in our skin, we'll just be constantly inflamed. We're constantly exposed to stuff. But you don't want to have any bacteria or any viruses within your blood. So the level of regulation is going to be much lower. And that's what you cannot compare an immune response in your skin, an immune response in your eye, or an immune response in your gut, or an immune response in your joint. They're all going to be different.
Interesting. What role does the concept of sensitization play in the context of metal allergies and immune system reactions to implants?
You mean sensitization prior to getting an implant? Yeah.
Sensitization prior.
So again, in order to have a potent immune response, you want to be sensitized first, and then you're going to have a second response, the re-challenge, where you would have a potent immune response. So in our daily lives, we're constantly dealing with metal objects. You have your phones, you have your laptops, people wear jewelry.
Your stainless steel Berkey water filter and your Yeti water bottles.
Exactly. We are constantly being exposed to different metals, to different things. And unfortunately, for people that are maybe more prone to becoming sensitized, they can get sensitized that way, right? Tattoos have tons of metal. So you are literally sensitizing yourself to the metals in your tattoos if you have those. And in the majority of people, it's going to be fine, but there's going to be a group of people in which that may not be okay with your immune system. So if you are pre-sensitized, and that's something that we can detect with our test at orthopedic analysis, you don't have to have an implant to show a metal sensitivity. You can be highly sensitive to a metal prior to having an implant because of your sensitization based on your previous exposure. There's a lot of jobs that require exposure to metal. Painters, they're exposed to metal. So in our daily lives, we have plenty of opportunity to become sensitized to different things. And that's the goal here, orthopedic analysis. We want to find those people before they get an implant. So we want to find how sensitized are you? And if you are, then have an open forum between you and your doctor where you have everything in front of you and be like, okay, well, it looks like I'm highly sensitive to nickel. Would it make sense for me to get an implant that has very low content of nickel or no nickel at all? Does the surgeon feel comfortable with that? Do you have the alternative implants that you can use? And thankfully, yes, the answer to all of that is yes. A lot of them do feel comfortable using a different type of device. A lot of them do want to use a different type of device, and everybody's content.
Let me throw out this to you. I have a specific patient that I know that comes to mind that wound up being allergic to titanium after a lumbar fusion surgery. Got the metal test, showed him only allergic to titanium and to no other metals. They go out and have a revision, revise with stainless steel. He didn't show any allergy to stainless steel. 4 months after the revision, all the symptoms came back, had another metal test. Now he's sensitive to stainless steel and all of those components. And that didn't show up prior. So some people have said there's this school of thought, why don't we test everybody for metal allergies prior to surgery? Then there's the other school of thought where the immune system doesn't react until the metal is present in the body and then it reacts after the fact. So is it good to test prior? Is it really glean enough information?
Both of them are correct.
Okay.
Yes, there are people that are pre-sensitized that we can find them. And there are going to be people that are not sensitized and will become sensitized after the implant goes in. And there's no other way of figuring that out. These people will become sensitized because the metal burden inside their body is probably going to be high enough to now get your immune system going. and only then you will start having problems with it. So that's very unfortunate. That's something that will happen. And there's really no way that we can detect those individuals prior to
So
that.
would you still say it's important to test prior, even though you may not respond to everything? Is it better than nothing?
The answer to that is yes. I think there's a huge amount of people out there that have an idea that they're sensitized. Again, cannot wear jewelry, have family members that have had issues. I think those individuals for sure need to get tested prior to surgery. You already have some indication. Why not just confirm it and bring it up before you actually have to get it? And these goes for our doctors as well, where again, if in a questionnaire the patient is telling you, I have a history of metal sensitivity to jewelry, my belt buckle, whatever, that's when they need to get tested prior to surgery. Now, if they say, well, I don't want to test everybody, even if they don't have any indication of a history of allergy, I would agree with that. It's not a cheap test. It's hard to do. It's a blood draw, sending it in. So I think that would be okay. But I think for somebody that has a history, pre-testing is probably a good idea.
Pre-testing and follow-up testing.
Yeah. And then obviously, if you now already have a device and it's not doing well, it's painful, it's causing a lot of issues. Obviously, metal sensitivity really becomes a diagnosis of exclusion because the first thing they're going to look for is infection. They're going to look for any mechanical issues with the device. After all of that has been ruled out, if all infection tests come back negative, if everything looks mechanically sound for the implant, but the patient continues to have inflammation or pain, effusions, rashes, then again, probably a good idea to get tested for metal sensitivity to see if that's the case.
I hope I asked this question in the right way, but I've heard of repeated people that have gone in for knee and hip surgeries, maybe other implant surgeries that have repeated infections. They've made it seem like it's not necessarily an actual infection. What is the mechanism for that? How does an allergic or hypersensitivity response show up as an infection? What does that look like biologically?
It doesn't. An infection cannot be a metal sensitivity. Infection is going to be exclusively for an infection with bacteria. So if you have all of the hallmarks of infection, which is inflammation, and you're going to have a positive test for infection for the type of bacteria you're infected with, now, a lot of people use that interchangeably because how the immune system looks in both scenarios is very similar. The difference is that one has bacteria and the other one doesn't. So a lot of people say, oh, I got earrings, and as soon as I put them in my ear, a couple of days later, I got an infection in my ear. That was likely not an infection. That is likely an immune response to the nickel in those earrings. So a lot of people use it interchangeably, but it's not correct.
So in the case of a hip or a knee implant, would a physician potentially not culture to see if there was bacteria present? They would just look at it and say, oh, that's an infection, when in fact, there may not be bacteria present and it could be a hypersensitivity.
Diagnosis of infection in orthopedics has become pretty difficult in certain circumstances. I think they will always look for that bacteria. There may be a lot of cases in which they look for bacteria, they can't find it, the cultures come back negative, but it may be because it's a very low grade bacterial infection where it's not detected on culture systems, right? There has been a lot of effort put into different modalities for infection testing, but I think there's still a bit of a gap between what really happens in terms of a bacterial infection and the diagnosis of it, and also the possibility that it's not an infection and it may be a metal hypersensitivity response. But there's a lot of wishful thinking too. Some people want it to be an infection, some people want it to be a metal hypersensitivity, and when they look very close, they don't really know which way to go.
Okay. How has the understanding of the immune system's involvement in metal allergies influenced the design and development of new implant materials?
I don't think it has influenced much, unfortunately. I think maybe the best thing that we can point to is the development of coated implants, implants that are coated with less reactive metals. So instead of having a cobalt alloy as your base, you have titanium nitride or zirconium nitride coated implants to basically hide the cobalt, the chrome, and the nickel in those implants. In other alloys that are completely avoid cobalt alloy altogether. So I think that is really the extent
Carbon fiber.
of correct. There's PEEK devices nowadays as well. I think is really just picking a different type of material. I don't know what else could be done in a hypothetical scenario. I know there are certain devices that may have some sort of antibiotic within it that can actually help with or prevent infections. So theoretically, you could have devices that can have some sort of anti-inflammatory biological agent that would prevent that metal sensitivity. But I think that's a little too complicated, and I don't think anybody would ever
Just need to be able to 3D
get into
print
that.
bone.
Yeah, well, that's the thing. That's when we will be out of business, right? That's the day that we will just have to move on to something else.
Could you share any insights into potential future directions of research where the interplay between immunology and orthopedic implant materials might lead to innovative solutions?
I think that the goal now is to collect as much data as possible and be able to provide both surgeons, doctors, and patient with a good idea of what the risk factor is in terms of their metal sensitivity. There's not going to be a yes or no answer, but there is going to be a risk factor number that we can hopefully tell the surgeon and the patient, saying, listen, based on your level of sensitivity, based on all the metals that you are reactive to and how severely you're reacting, based on your history of metal allergy, because of your not being able to wear jewelry, etc. Based on that, you have X risk factor to having a biological response to your implant within the first few months or first couple of years, so that everybody goes in on the same page, where everybody agrees to what's the best possible implant the surgeon and the patient can use for that specific case. I think that is really going to be the advancement that we're hoping to see, at least through our company, and make sure that it becomes more useful clinically to orthopedic surgeons when it comes to figuring out what type of device to use.
This might be a bit of a departure, but I read briefly in some of your literature that most implants fail after 20 years. Is that because even the healthiest person after 20 years of exposure to this foreign material is going to have a stronger immune reaction 20 years down the road?
Yes. Remember, we talked about innate immune reactivity, which is kind of your first line of defense,
Yes.
and adaptive immune reactivity, which is your lymphocyte reactivity. So in the best case scenario where you are completely non-reactive, your T cells, your lymphocytes do not care about metal, you're good to go. Your innate cells, your macrophages, they are still going to respond to the degradation products of the implant. So every implant is going to corrode over time. Every implant is going to release a certain amount of particles and a certain amount of corrosion around the implant, and your macrophages are going to be there constantly, inducing these very mild pro-inflammatory response that may not matter in the first 5, 10, 15 years, but as more wear debris is created, more of these inflammatory response starts affecting your bone metabolism. Eventually that implant is going to become loose and you're going to need a new one. So that isn't the best case scenario. If these did not occur, then yeah, theoretically the implant should be there forever, right? Why would it become loose?
So then if you're sensitized after 20 years, how do you then get another one?
Well, that's a tough question, right? But the good news is that if it happens, you can never say never, because there have been people that never had an issue, and then all of a sudden, 5 years, 7 years, 8 years down the road, all of a sudden they become sensitive.
That happened with my mom with a plate in her ankle. Say she had, after 10 or 12 years, she developed what looked like infection, and it just was inflamed all the time, and they eventually had to pull it.
Correct. And the only way that I can think of that is that it was just at that point where the burden of metal that your immune system was able to be exposed to was high enough to now become sensitized and induce a response. So yeah, it can happen for sure.
Okay. How do you collaborate with other experts in the medical field to ensure a holistic response to patient care and implant safety?
Testing is obviously our main thing. The conversation that I'm having with you is a conversation that I have with a lot of allergists, a lot of orthopedic surgeons, a lot of family care physicians. So that's really the way that we do it. We try to educate anybody that has any questions about the basic science and the clinical outcomes of metal sensitivity to orthopedic devices. Our main goal is really to show how complex it actually is, how metal sensitivity is an issue that affects a lot of people and is going to induce biological responses in a lot of patients, but it's not a yes or no answer. It really is patient dependent, and there are all these mechanisms that are involved. We really try to come in conjunction with the patient's surgeon, the patient's allergist, and try to come up with the best possible solution so that the patient can get the best possible implant for them.
What do you think the biggest misconceptions are regarding metal allergies and metal implant degradation in the
Oh man,
medical field?
where do we start? Well, the first one, it doesn't exist, right? I want to say it again. I think the vast majority of surgeons understand the topic. Maybe some of them don't want to visit it, but they understand it. They believe in it. And a lot of them take action when it comes up. But there's a very small group still out there that really think that it doesn't exist, or the answer is it never happens. You may have some allergy in your skin, but it's not going to happen inside the body, right? So I think that's the biggest misconception. Let's say it's not a real phenomenon. The second biggest misconception is that if a patient is positive for metal sensitivity, they believe that equals implant failure, or that is going to lead to implant failure. So a lot of the questions are like, I have a patient that is metal sensitive and they have an implant and they're doing just fine. And that's great. That's actually the way it's supposed to be. Maybe that patient is not sensitive enough, or maybe that patient's immune system has not released enough corrosion products or wear particles or metal ions to induce a response. Being metal sensitive does not immediately equate implant failure. It equates higher risk of implant failure. So
Okay.
that's another big misconception. The third one is like, is the patient allergic or not? Again, a yes or no answer.
And
And
the answer is
it's like, yes, sort
kind
of.
of on a scale, on a
It
spectrum.
it depends. What are we talking about? Are we talking about these metal or that concentration or the other concentration? So that's another big one. I think those are the three main misconceptions, not only for surgeons, but also for patients. A lot of patients feel like that if they are sensitive to a metal, that is going to be 100% an implant failure, and it's not the case. Maybe a higher risk, but it's not going to be a 100% possibility of implant
I
failure.
thought it was interesting, and you correct me if I'm wrong, that I read in your research that 20% of implants fail. 20, that is.
Yeah, it depends. When it comes to knee replacements, right? There's close to 15 to 20% of people that are actually unhappy with their knee replacement. It's idiopathic, like they don't know,
But
cannot
what are you
figure
going
out
to do?
why
Chop
that
your leg
is.
off? I mean,
Exactly. I am willing to say that
yeah.
a pretty good chunk of them probably is because of a metal sensitivity. Because once a patient comes back with pain or discomfort, the first thing they're going to do is look for infection x-rays. And if everything checks out fine, they're like, we just don't know why you don't feel that great. It is what it is in a way. Orthopedic devices, they're not perfect. They do help millions of people for sure. It's a great advancement in science, and it has helped many, many people improve their quality of life. But it really is about that percentage of people that we're still trying to figure out what goes wrong. How is the interaction with the immune system affecting that? And how do we
Well,
fix that?
I think you bring up a good point, and this is another misconception that I think I've encountered on social media in different places is that people that are metal allergic are anti-metal, anti-implant, anti-surgery, anti-doctor, and none of that is true. It's have the surgery, have the implant, but do due diligence, have a plan for controlling collateral damage or collateral symptoms if you have them,
Absolutely.
et cetera, et cetera. And many doctors are medically brilliant. There are great doctors, and advances in science and medicine is phenomenal. I would never tell somebody don't have your infected gallbladder out or don't have a
Right.
cardiac stent. Please, by
Right.
all means, choose to live. But
Absolutely.
but we need to screen ahead for metal hypersensitivity. Need to use the least offending metal. We need to have a plan for how to handle any systemic reactions that occur afterward and realize that they can and do. And then in the case of orthopedic surgery, have a plan for removal once you heal if needed.
Absolutely. If I need a knee, they're going to screen me for, do you smoke? Are you obese? Do you have high blood pressure? All risks for a bad surgery, right? And if I'm
Mm-hmm.
any of those, likely they're going to try to fix that before I have my surgery. Metal
Yes,
sensitivity should be no different than that. It should just be
correct.
another potential risk factor for any surgery in which a metal device is going to be inserted into your body. Again, we're not saying no answers. It's just find out, measure your risk, and then make a decision. There may be a guy that smokes out there, and surgeon is saying, I don't really want to do the surgery on you because you have a higher risk for something happening because of your smoking. And the guy may be like, you know what? I'm
Well,
fine with it.
surgery isn't a magic fix, it's a trade off.
Exactly. So, yeah, understanding these as an important risk factor, I think is really the goal. Hopefully, that keeps changing as it has in the last 10, 15 years.
How does your company contribute to raising awareness about systemic metal allergies and educating medical professionals and the general public?
Every day on the phone. I touched on these a little bit before. I think
Yeah.
our main source of marketing really has been our scientific publications and our conferences and talks at the major orthopedic conferences in the United States. We constantly go to the American Academy of Hip and Knee Surgeons, which happens in Dallas every November. We have had a booth
Hey,
there for the
we can have
last.
lunch.
Absolutely. So I'm there sometime early November.
Oh, we'll do it for sure.
For sure. Heck, I'll have you come to the booth and you can be there with us. I love going to those conferences because we see the guys that do testing with us all the time. So, high fives, hellos, how you doing? That's awesome. Everything is wonderful. I still get a lot of surgeons that come to us and they're like, oh, I've never heard of these. And I'm like, you have to be kidding me. So we obviously explain what we do, basically have the same conversation we've had with you today. So then they understand it. So that feels really good. That's amazing. And we still have a lot of the guys that sometimes stop by and say, I don't really think this is helpful. I honestly try to change their minds based on all the facts and all the science. And that's all I can do.
And I'm trying to showcase as many patient stories on the
Right.
podcast as medical professionals, because when you hear from the patient, yes, that's anecdotal evidence. But when you have enough of them saying, I was dying and I had the metal removed and now I'm healed, when you get enough of that, people are going to start to pay attention.
Absolutely. Since its inception, orthopedic analysis goal really has been to show orthopedic surgeons why this is important, why it matters, how it happens. American Academy of Orthopedic Surgeons happens every year between San Francisco, San Diego, New Orleans. I believe the next one is going to be in San Francisco. We will be there as well. We always have our booth. And I always find it fascinating because we have our small 10 by 10 booth for orthopedic analysis, and we're amongst multi-billion-dollar implant companies. And I love it. I love it because we will never be able to go away because the science doesn't lie. The science is there.
What's the response from the device manufacturers that are there toward orthopedic analysis?
It's great for the most part. We have a lot of sales reps that use orthopedic analysis with their surgeons. We don't really have anybody coming to our booth to tell us why we shouldn't be there. I don't know if anybody feels that way, but the vast majority of people that come to us find it helpful, find it interesting, and they want to help their doctors, they want to help their patients. I think we've been going to these conferences for the last 10 years now. And we also submit our research to the same conferences. So fingers crossed, we have either a scientific poster or a talk to give at AAOS this coming year. Basically, that's what we do as a company to really try to get the word out there, not only to tell them metal sensitivity matters, but to tell them why it matters, how it matters, and what the data says.
Can you see yourself dealing with any of the smaller implants like surgical clips and staples and doing studies for that, biopsy markers, the cardiac stents, the smaller implants? Is that something that you would be interested in publishing more research on and getting more involved with? Because I think that's probably as big a deal as the bigger implants.
Yeah, absolutely. The reason we do a lot of orthopedic research is because we are associated with Rush University Medical Center, Department of Orthopedics. But we have the ability to do research testing for really any component any physician would like to do, as long as all of the components are in place in terms of IRBs and all of the regulatory mechanisms. We are open to all types of research when it comes to metal sensitivity, whether it's clips, whether they're cardiac stents or what have you.
Talk about what that involves, because I'd love to be instrumental in helping facilitate that.
It's a topic that is really getting out there. We found this company, Boston Scientific, has a specific type of cardiac device. It's called the Watchman. It's a cardiac device for AFib. On the brochure for the device, they have clearly listed as a contraindication not to be used by people that have a metal sensitivity. And I think that is a really important step forward, because I have seen more of that lately, where you have device manufacturers putting a contraindication, at the very least saying, these should not be used for people that have a metal sensitivity or a metal allergy. That is going to force physicians and force patients to, at the very least, find out or get tested, or at least have the discussion with their doctor about it before getting it. I've seen a couple of orthopedics manufacturers do the same thing, and I think you're going to see more and more of that in the future.
That's great. What advice would you give to aspiring researchers or professionals interested in the intersection of immunology and orthopedics.
Do it. It's fascinating. It's very rewarding. I think there's still a lot that we don't know. There's still a lot of science that needs to come out, both at the basic science level and at the clinical level. Like I said, we are not going to have less devices in the future. We're going to have more devices, more complex devices. And all of them will likely have a lot of metal in them. So we are going to need more science, more research, more information as to how and what it means to respond to these devices. The academic environment is very tough right now. Funding for basic science research is at an all-time low, but there are many ways of doing these.
How can we change that and get the FDA on board with funding these studies for the rheumatology drugs to show the hypersensitivity, to fund the studies that proves that this is a big deal and we need to take more time?
Yeah, it's the big fight, right? It makes common sense to us. I guess it doesn't for people that are not affected by it. But yeah, it's common sense and it's just, it's just politics. I think funding is scarce for a lot of different things. So I don't see that they're looking at these as a priority, but it's definitely something that is important to look at. But don't let that dissuade anybody from trying to do it. I think, again, it's a fascinating topic that is just growing. The field of osteoimmunology has been there for a long while. It's something that we need to keep looking into. It's very important.
I have a list of questions from listeners.
Awesome.
There's some people out there that really want to know what you have to say on a couple of things.
I'm ready to go.
Somebody has asked why you changed the range and what is the science?
Oh my goodness, I love that question. One of the main criticisms or questions that we had from a lot of healthcare providers is, okay, so my patient is in the reactive range at a 4.5 or a 5.8 or a 12.0. Now what? What does that mean? And it was a legitimate question. All I can tell them is, yeah, that's pretty high. It means that the patient is sensitive. So we try to figure out, how do I measure what a potent immune response is? What do I compare it to? What can I make it clinically relevant so that we can explain to our healthcare providers? So when COVID hit, obviously it was a horrible thing for the whole world, but immunologically, it opened up a door for us to do something. What we did is, for the first time ever, at least in our lifetime, we had people getting vaccinated to an antigen that has never existed before. This is purely scientific technology stuff. So basically, first challenge, if we are to now get these individuals' blood, their lymphocytes, their PBMCs, their immune cells, just like we do for metals, and we challenge those PBMCs just like we challenge the lymphocytes with metals for people that look for metal sensitivity, right? Now, we theoretically should have a potent immune response because people have been primed, they have been sensitized, they have been vaccinated for these specific new antigen. So that would give me an indication of how potent clinically relevant immune response actually is. So we set out to do this study for COVID, LTT, to see how potent the immune response is and how that response compares to a metal sensitivity response. This is going to be published. There's some of it already published, but the main article hopefully will be out in the next month or couple of months showing these. So lo and behold, we had a group of people that had not been vaccinated yet, or did not want to get vaccinated. And we had a group of people that were vaccinated. And then we did LTT on those two groups of people. So sure enough, the group of people that were not vaccinated, the median immune response was pretty low. There was no level of reactivity because they had not been vaccinated yet. And the people that were vaccinated, that response was crazy high. Those lymphocytes were moving, proliferating, inducing inflammation, which is what they're supposed to do. 95% of the people in that group had an SI, or stimulation index, in our test above 4. Nobody in the vaccinated group had mild reactivity to the COVID vaccine. Everybody had 4 and all the way up to the 20s. So for the first time, we were able to show what a clinically relevant immune response looks like in terms of the range. So now I can tell surgeons, look, your patient responds to metal the same way that an immune system would respond to COVID after you have been vaccinated. That should really mean something. It really shows how potent an immune response can be to metals because you can compare it to the response to a new antigen that you have been vaccinated against. So because of that, we changed the range of reactivity. Instead of being 2 to 4 mild, you're going to be either reactive if you are at 4 or above, or highly
Okay.
reactive if you are 8 and above. And that's really the main reason why.
Now, this is interesting. I'm going to ask you from an immunology standpoint. I'm going to use myself as a guinea pig again, because
Sure.
why not?
Yeah,
So
for sure.
when I had the orthopedic analysis test, my nickel came back at the higher concentration as a 6.7,
Okay.
which is moderate. But when I've had other food allergy testing or other testing, and I know I have food allergies, I know I have things I'm sensitive to, but when I have regular IgE, IgG testing, and I have alpha gal, which you're aware is the tick-borne allergy to red meat. I have that. I test negative for that. I test negative for every single food allergy. And then I test mild or moderate on this nickel when I know my nickel reactivity for me is literally off the charts based on my experience. I do have low total immunoglobulins. Could this be a factor as to why I don't register on an IgG, IgE scale?
It's a possibility. I think in terms of food allergies, do you have the type of food allergy where you would just get hives or it's just discomfort in your intestines?
My food allergy is all the high nickel foods. And
Uh-huh.
even before I knew that nickel in diet was a thing, sometimes it's an oral reaction. And I think that's a type 1 reaction, right? An immediate oral
An
allergy
immediate,
reaction. And then
right.
I also have the delayed, like with alpha gal. If I eat dairy or meat, I
Yeah,
don't react for about 6 hours. And then I have systemic pain, GI symptoms,
right,
frequent
right.
bowel movements, but I still have a negative alpha gal test. We know I have it because I got 2
Huh.
tick bites 2 weeks later out of nowhere. Couldn't have
Yeah.
gelatin, couldn't have collagen, couldn't have dairy, couldn't have mammal, to the point where if my compounding pharmacist makes a capsule with gelatin, I know, and they don't even have to tell me. I call them and say, "Did you make the wrong capsule?" "Oh yeah, we did." I mean,
Right, right.
I have it, but if you look at the alpha gal panel on Quest, the IgE, it's negative.
Yeah, I don't really have the answer to that. Antibody testing, it's a great test to do. At the same time, people need to realize is that antibodies tend to be transient as well. They're not going to be there forever. You can detect antibodies likely immediately after your immune response, your allergic response, and they'll stay there for a while, but over time, they're going to go down. So you're not going to find the same level of antibodies if you test now and if you test, let's say, a few months later.
Yeah, I didn't have
Right?
any ever. I mean, not that they found.
Right. So the key thing here, and that's the way your immune system is supposed to do it. Your B cells, which are a different type of lymphocyte that actually makes antibodies, you also have memory B cells floating around your body. So not until you actually get re-exposed to that antigen you're allergic to, whether it's your food or something else, then those B cells that are going to recognize that antigen again, and they already know it, they're memory cells. They'll be like, oh, here it is again. Boom, they're going to release tons of antibodies again against that specific allergen. So it would be interesting to see if at one point you actually consume a food that you're allergic to, right? And then maybe a day later you do the antibody test. My guess is that your antibody levels are going to be super high.
Interesting. Well, they've never been high. They never even shown up. So I feel like I've
Yeah.
got no immunoglobulins or something. I don't know.
Yeah, and again, like I said, everybody is different, right? Like maybe you are designed in a way where your humoral immune response, which is your antibody response, may not be as potent as your DTH response. God knows many factors come
God
into play.
knows. I'm going to
Remember,
donate my body to orthopedic analysis. Let you guys figure it out.
we'll see what we can do.
Tell me on the other side. Okay.
Right.
So here's another question. So are there people who show up reactive higher to the smaller concentrations that you measure versus larger concentrations? Why is that? And is it clinically significant? Is it still a reactivity that's significant on a clinical basis?
Yeah, absolutely. Just as if everything that we've discussed is not complicated enough, I want to make it more complicated now.
Okay.
It seems that many people's lymphocytes or PBMCs, which are the cells that we get from blood, have different tolerances for toxicity. Okay, there are certain metals that we know are pretty toxic, like cobalt and vanadium.
Yes.
But we do see people that are not good at tolerating higher concentrations of metals. And that's the reason we have the range that is basically 10 times stronger each time we go down. So what it means is that your immune cells are responding to the lowest concentration because they were reactive.
Yes.
They found the antigen as foreign, and then they're going to proliferate. But as you increase the concentration, it has become too toxic for your lymphocytes to tolerate. So now your lymphocytes are like, this is too much aluminum, too much vanadium, too much cobalt. I'm dead. Just too much of a burden. And then they die off or they become anergic. Anergic meaning that they're not going to do anything. They're not going to proliferate. They're just going to sit there. And that's very important because now imagine that dynamic around your implant where you're releasing metals that may be killing off some cells, right? Inducing a toxic response, which also induces inflammation. At the same time, you may be inducing a hypersensitivity response with the metals that actually are at the right concentration for an adaptive immune response. So you could have both things going at the same time. But yes, the ones that are at the higher concentration is because that amount of metal has become too toxic to those lymphocytes. And because everybody's different, I have seen people that when they're allergic to cobalt, they will respond only at the lowest concentration, and the cells are dead at the higher concentrations. And in some other people, they respond to all three of them all the way through.
That's
right?
Interesting.
So it's a concentration dependent reactivity. It's hard to translate to what happens in vivo, but nonetheless, I think it's important to acknowledge and understand that it can happen.
Okay, that works. Here's another question. Sabine asked, what does the orthopedic analysis test tell us in comparison to the Clifford ELISA biomaterial test, looking for insight into type 1, 2, 3, and 4 hypersensitivities?
Oh, that's going to be a tough question to answer because I know nothing about the Clifford test. I have heard certain things about the Clifford test, and I don't want to say it because I don't know, but I feel that they were looking for some sort of antibody reaction or something like that. All I know is that I don't think they're still around. I think that company has basically closed its doors. That's all I'm going to say about that because I really don't know much about what they did.
Yeah. She also asked, is there zirconium in dental crown form releasing metal ions?
I think zirconium in dental crown form is really a ceramic. I think it becomes a zirconia, which is different than zirconium. So my answer is probably not. If it's a zirconia dental crown, that's more of a ceramic type of device, which is basically not a metal anymore. It's more of a ceramic component.
Well, I will throw out, and I don't know if you have any input on this, I rejected a pure zirconia dental implant that was supposed to be metal free. And I did find a PubMed journal article that said that there were trace metals in zirconia metal-free implants.
Oh, that's interesting. I don't see that out the realm of possibilities. It's hard to get rid of metal. Metal is everywhere, right?
I'm so sensitized that
your immune system is crazy. You are like a special case of, hyper immune, which is fascinating.
Unless you're me, and then it is not fascinating.
I got it. Totally agree. Yeah.
It's a horrible, awful idea.
We had somebody in our lab. She responded to things, normal things that we would respond to, whether it was a virus or what have you, any antigen. She will always respond like 20 times or 30 times stronger consistently. Yeah. She has basically a very hyperactive immune system. And it shows clinically because anytime that she gets sick with a regular cold or flu, it sends her to her bed for a day or two because we know that her immune system is just going completely overboard with something that shouldn't have been that much.
And mine just makes me look crazy because I do have, clinical proof, but I don't have that kind of extreme reactivity. I have it in my body, but I don't have it on paper. So that makes doctors look at you and go, huh.
Yeah, and that's the goal here, at least for metal sensitivity and implants. It really is to show physicians, look, there is a range here. Again, it's not black and white. There is a range of reactivity and people respond differently, and you need to be careful with that.
Okay, another question. Have you developed testing for suture reactions?
When you say suture reaction, these are metal staples, I'm assuming?
I am unclear. That was just the question.
I
do think I had a listener email me that has orthopedic surgeries and they used suture anchors, I think is what they were called. And I'm not familiar actually with
Right.
what that is.
Yeah. So if those are non-metal anchors, then no, we have not. Basically, our panels are designed to contain the metals that are mostly found in most biomaterials, cobalt alloys, titanium alloys. Our extent of non-metal challenge agents are bone cement, which is a polymethyl methacrylate in its particulate form and in its monomer form. That's it.
But perhaps with her question, if they're reactive to metal, maybe there is a higher risk for suture reactions, even if they're not metallic, due to just the presence of foreign bodies and the immune system being in overdrive.
It's a possibility. I think hyper innate reactivity, I don't think it's too well studied, but I think it's definitely possible.
Do you know much about Asia, which is
I
the
I do not.
autoimmune? It's the autoimmune inflammatory syndrome induced by adjuncts. There's a whole body of research on Asia
Right.
syndrome, which is basically if you have a
But
foreign body or adjuvant of any kind, you can be reactive.
yeah, again, adjuvants, they're meant to induce an immune response. But they were used in vaccines, obviously, so they can induce a response and pick up the
Yeah.
new antigen. I don't know if you were able to see, we published in 2017 and showed how clearly how females all across the board have higher severity and higher percentages of metal sensitivity compared to males. Females just have a far better immune system than guys do. And that's what you guys outlive us all the time. It's an interesting fact. It's not just for metal sensitivity, but autoimmune disease. Females have more because you have a higher immune response to different things. So that's really interesting as well.
Okay, well, I have one final question in a minute. We're wrapping up, but tell us what we haven't covered that you want to leave us with. What have we not touched on that's important to you?
I think we've touched on a lot of things. I think this has been great. By the way, thank you so much. This has been a blast. I love talking about these. And something that I want you and your listeners to know is that this conversation happens on a weekly basis with many people at Orthopedic Analysis. I wish there would be more platforms like yours where we can get to even more people out there. I think we've tried to cover everything. I think what I want to say is that, again, the vast majority of physicians that deal with patients that have a metal allergy, they mean well, they understand it. Sometimes they're not well informed as to what can be done about it. There may be a little bit of maybe a skepticism or concern about liability. So they don't really know which way to go because they have not been provided with guidance as to you have to do these or you cannot do these, right? But I think that is changing. And I think the hope for all of the metal sensitive patients is that is starting to change. I think there are a lot more physicians that are well aware and are taking action. I think that in the near future, everybody will be asked to disclose if they have any history of sensitivities in the past and are going to be able to basically go through that list with their doctor before they perform any surgery. So I think that there's a lot of hope in terms of things changing in terms of metal sensitivity and biological responses. It's very important to be on the same page with your physician. I think these are maybe something we haven't covered and I think is important. We do get a lot of phone calls from physicians and from patients that want to do the test, but their doctor does not want to do the test. That becomes extremely difficult, right? Because you need to have a physician that is working with you and understands your concern and is willing to test you and is willing to go over the results with you. If you know you have a metal sensitivity, if you're concerned about it and you want to get tested, I think it's important to have a healthcare provider that is on your side, that is willing to go over that with you before anything happens.
So maybe a new doctor is in order if you don't get what you need on the first go around.
At the very least, a second, third opinion, because otherwise it's going to make things difficult. If you actually do have a history and you turn out to be sensitive and there's no validation or there's not a belief that this is a real issue, that could potentially be a problem down the road.
I don't know if you know, I have just placed a petition online on change.org. You can link to it on the website. I think Orthopedic Analysis has talked about linking to it. Probably get Melissa to link to it as well. But anybody who wants to can link to this petition to petition medical providers, hospitals, surgical centers, and doctors' offices to screen patients for metal hypersensitivity and to have informed consent. It's a very well-written petition. My goal is that people will go and we will obtain thousands and tens of thousands of signatures on this petition. Maybe we can even circulate it at some of these events. I've got a flyer with a QR code. And if we can get many thousands of signatures on this petition, then eventually my goal is that patients will be able to print off this petition and take this to their doctor, to their medical center, worldwide. I'm only one person. We can present it at conferences. We can present it to the FDA. And the more people that leave a comment, if you've had a metal reactivity and you've had an experience with a revision that worked out well, state it in the petition. And the more comments and the more signatures we have, the more people will start to realize that this is a real issue affecting many thousands of people. So I think together we can all affect that kind of change. Okay. Final question.
Absolutely. Yes, ma'am.
What is your favorite heavy metal band and your favorite heavy metal song?
Goodness, you put me on the spot. Heavy metal band.
You cannot come on the Heavily Metal podcast without answering those questions.
Okay, so I think of the heavy metal bands that I know, and I think I have a couple of them, a couple of songs on my phone. So we have Quiet Riot and Twisted Sister. I like them.
The Love Our Ending.
Oh, that's right. We're Not Going to Take It. Right? That's probably one of my favorite songs.
We're not there yet, but we're getting there in a minute.
Got it. Yeah. So, those are, I think, my two, I would say, favorite heavy metal bands. There's other ones that I don't even know if they qualify as heavy metal, but...
What's your favorite heavy metal song? Do we have one of those? Those qualify.
So I like Metallica, and I know Metallica, I forgot the name of the song, but it's not the heavy metal song, it's the mellow song that they have.
Nothing Else Matters?
Nothing Else Matters, that's correct. Yeah, love that song, listen to that. Yeah, absolutely.
You and Linda Nelson from Eliza both like Metallica. Did you
Is that right?
That in common? Yes, that's her favorite band.
Oh, we got something common. All right.
Go Metallica. All right. Well, we're going to wrap up. It has been absolutely a delight having you. I can't wait to see where we all go in the future with this. I'm planning on big things. Metal allergies needs to be bigger than gluten. And until then, we're going to stand up and tell the medical communities that we don't like being gaslit. Metal allergies are a real thing. We are advocating for change, and we're not going to take the same old anymore.
Awesome. It was a pleasure.
Thank you for tuning in today. Please don't forget to follow me on social media and to like, share, and subscribe. My primary mission is reaching out to others who may be suffering from hypersensitivity reactions to metal implants and pointing them to resources that can assist with hope, help, and healing. If you know someone that suffers from a chronic illness, you might ask if they have any implanted metal hardware and if they've ever had a reaction to jewelry or metals of any kind. Might not even be on their radar. Visit us at heavilymetal.com where you can find images and documentation relating to our show today, as well as a number of valuable resources and links to assist you on your own personal healing journey. Until next time, keep on rocking.